Hi, this is Mish Hancock, and you are listening to MichMash, a place where I get to talk to the weird, wacky, wonderful people of this world, people I adore and want to know more about. Today, my guest is Chad Sabora. Chad is the co-founder and executive director of the Missouri Network for Opiate Reform and Recovery. He is a former prosecutor and a recovering addict. Chad's vision is to shatter system sameness through drug policy reform that reduces harm by looking at what we know now about substance use. Hello, Chad.
Hey, Mitch.
And I remember you told me that I had to say substance use, not substance abuse.
Exactly.
Right. Tell us why.
We have to focus on language changes these days. This is a mental health condition. Whether we want to have the argument about it being a disease or not, I just don't even entertain those arguments anymore. We know it's a mental health disorder. So we have to start using appropriate language. We're not drug addicts. We're not all these other things that we've been heard about. I have a mental health issue, and I'm a person in long-term recovery from that issue. We take cues from other historical ways we dealt with other mental health issues. The way we used to categorize and stigmatize people in mental hospitals. We used to call them insane asylums. We used to do lobotomies. We're going to look back. We look back now 50, 100 years ago at how we treated the people that were, as we called them, insane.
Right.
With horror. We used to warehouse them in mental health hospitals, lobotomies, shock treatment. The things we used to do to people with mental health issues is shameful.
Right.
We're going to look back 100 years from now and look how we treated drug users with those same eyes of shame. So we have to take cues from what we know works. What we know works is language is a key part of this.
It is a huge part. And talk about that, because whenever someone hears drug addict, right?
Yeah.
What do they think of?
Criminal, in some alley, in a shooting gallery, robbing old ladies at ATMs. Those are all the thoughts that come to mind, and that is not actually true. I mean, I used drugs off and on for 17 years. The only crime I ever committed was putting a substance in my body that I was told I couldn't put in my body. And I'm one of many drug users that would fit into that mold.
Right.
Not all of us are that image that pops in your head when you hear that word. There's plenty of people out there that can recreationally use illicit substances, even your more addictive and what we call hardcore substances, I guess, with minimal to no consequences, and they can still go to work, function in society. It's actually the minority of us that use illicit substances that will clinically develop substance use disorder. So there's an unspoken majority out there that just doesn't want to come out the closet and say, yes, I use heroin once a month, or I can do cocaine once in a while and put it down. That's actually the majority.
Really?
And, yes.
Oh, educate me on this. I gotta tell you, I was under the impression that such substances were so addictive that if you go to use it, that's it, you're done.
That is the 1980s dare. You smoke crack one time, you're addicted.
Right. Yes, sorry. I'm dating myself, but no. Tell me.
I'm a product of the 80s dare program. No, I mean, this 1 in 5.
Really?
Is typically who will use substances and develop substance use disorder. So that's 1 in 5. That's not 5 out of 5.
Right.
Just because I put something in my body that's addictive doesn't mean I'll become addicted. There's repetitive use. There's lots of things that we'll go into. Somebody, 1 in 5, whether it be mental health disorders, trauma, adverse childhood effects that they had growing up. There's a lot that comes into play here, but we always have to differentiate the difference between physical dependence and addiction. 2 separate things.
Gotcha.
Addiction is not necessarily always defined by do I use a substance. It's defined by the consequential behavior of using said substance. We're all physically addicted to something. Coffee, nicotine,
sugar. We were just talking about all that.
Tons of individuals out there on antipsychotic medication, antidepressants, that if they stopped taking them immediately, they would suffer severe withdrawal symptoms, just like an opiate user would suffer withdrawal symptoms from not taking opiates anymore. So we really have to look at this much differently than just this broad stroke of you use this, you're a drug addict.
Got ya. That is so. What else do we need to know? What? I mean, dispel the myths, right? There's a lot of myths out there, and that's part of why I love that you came on today. Because I want to know. I want to know what am I seeing and hearing through the media that is not exactly on point.
Pretty much everything.
Yes, this I've come to realize with. So.
Well, the media loves to use the phrase opiate epidemic. It is neither singular to opioids, nor is it an epidemic. If we look at CDC death data, we can see that every drug use is on the rise. We're seeing a rise in methamphetamines, cocaine, alcohol, you name it. Then if we go back to the mortality rates, we see this rise in deaths from opiates started 40 years ago.
Really?
So epidemics don't last this long, and it's not just opiates. But it's good for the press because opiates in the United States, Missouri is a little different, have really infiltrated your rich suburban white neighborhoods. So we can put that out there, like these young white kids are dying, so people actually care. When it was the crack epidemic in the 80s, the answer was Ronald Reagan's Anti-Drug Abuse Act of 1986, which is what created that disproportionate sentencing between crack and powder cocaine. Just very racist policies, plus Just Say No campaign, that's something important to talk about, is our shift when a population that our government actually cares about starts dying. Now it's a disease. Now it's an epidemic. Now here's $5 billion. Well, where was all this funding when it was black people that were dying?
Right.
Missouri,
right.
However, is one of 7 states where per capita the black population is dying at higher rates than whites. Fill a void. So there's lots to come into play. Nobody is spared substance use disorder. It could happen to anybody. I mean,
right.
I was a prosecuting attorney, in Chicago with a house in the suburbs, 2 dogs, 2 cars, fiance, and I still put a needle in my arm. But there are some precursors that come into play here. Poor health, lack of resources, lack of education, things that our government has done to minority communities on purpose.
Right. I mean, and so for some of these communities, there's no other option for making a living.
No.
There's not like there's a place you can go work down the street.
No, and if we go back to the 80s with what was known as the Dark Alliance with Freeway Rick Ross and our CIA that was helping to fund Iran-Contras by supplying South Central Los Angeles with kilos of cocaine that could be turned into crack. I mean, our government and the powers that be are implicit in helping destroy minorities, especially with our drug policies. Dating back to when I gave my TED Talk, getting back to our policies around the Chinese in the mid-1800s who had brought opium to this country when they were building our railroads. We went after that population because we were fearful that they were going to turn white women into their sex slaves. We went after the black and Hispanic population in the 30s over marijuana laws with the same fears that it was going to make white women want to sleep with minorities. It's absurd.
Oh my gosh. We're going to take a quick break. We will be right back with Chad Sabora. I want to talk about your TEDx talk, but what else do you want me to make sure that we talk about?
It's up to you. Totally up to you.
Don't have a top of mind, Miss. This is really important. Let me talk about this.
No, my brain's a little foggy.
Okay.
So.
We'll just ask questions and unfog you. Have more coffee. I know, it's so true. I couldn't, I
got a 3-year-old and a 1-year-old.
I have to, oh my gosh, do you get sleep? Your 3-year-old is so cute.
Yeah, he's a good kid.
He was adorable.
Yeah.
So I had a bottle of water, and he was like, I think that's my bottle of water. And I'm like, okay, I just gave it to him, whatever. And then he came up to you, and you had his bottle of water, and he was like, oh, oops, no, and he came from my back. I thought it was just so cute. I'm like, oh my gosh, this kid's really aware, for being 3.
I'm just getting used to being a full-time dad, so we're live, so.
All right, are we ready?
We're ready. Let's do it. Here we go.
We're back with Chad Sabora, and so let's talk about your TEDx talk.
Okay.
I mean, what was the experience like for you? How did it feel to be at the event? Just tell us.
It was a really great event. It was an honor to be there. A little nerve-wracking. I'm not one for preparation ever. So that TEDx talk I gave was actually like an hour and 20-minute lecture I give normally. PowerPoint, lots of pretty pictures, lots of time for explanation and questions. And I had to scale it down to 13 minutes.
Don't you like how we do that, do you?
Yeah. But I do think I was able to get everything into the talk that needed to be said to educate people that our current policy system is very harmful. It's still based on criminalizing drug use, and it's based on very severe prohibition tactics. We have something that we call the Iron Law of Prohibition, which was coined in 1986, but you can go back to the data to the 1840s. When you prohibit access to one substance without giving treatment resources or any type of community help, all you're doing is turning people onto the next dangerous alternatives. We've seen this systematically happen with our opioid epidemic when it was painkillers, starting in 1996, and then in 2008, with our policy work on trying to limit access to painkillers, we saw a huge spike in heroin use because we took everybody and we sent them to the black market, mainly to get painkillers because they were cut off. However, painkillers can be very expensive on the black market, and heroin is much more readily available and cheaper. So we played a part in that. Instead of just creating treatment resources, we didn't do that. And then we're seeing the same thing happen with fentanyl today, but that's more of a natural occurrence based on the fact that fentanyl is a synthetic. You don't have to grow poppies. You traffic it in micrograms, not grams, so it's much cheaper to get across the border. And when I say border, there's lots of routes of entries for fentanyl. A lot of another myth to dispel. Most of our fentanyl that's coming to the United States comes through the U.S. mail system via the dark web, and also through port cities such as Baltimore. You see your highest concentration of fentanyl in the Midwest and on the East Coast, New Jersey, Baltimore, New York. You are still seeing what we call black tar heroin in the Southwest. So there are drugs coming up from the South, without a doubt, 100%. But you're still seeing more of a crude, more version of heroin coming up through that routes, and most of our fentanyl is coming in from different routes. These labs are based out of Turkey and China, and there's been a recent declaration from China to shut down these labs, but I doubt that will happen.
Right.
And if they do, another country will pick up on that revenue source to supply our country's insatiable thirst that it still has for opioids.
It's not. It's such a huge. I mean, I applaud you because it just feels like so much to try to figure out this issue, and how do we bring it to a place where we can provide health for people that and help and health for people that really need it. Yeah. Talk about some of the more immediate efforts that you guys are putting into place.
Well, the most immediate efforts is we have to change our point of contact, our continuum of care. The old guard treated drug users like, okay, well, when you're ready for help or you're ready to stop using drugs, call me. Or they'd have to wait for, let's say, a criminal justice intervention or something. But there was always that barrier of, I'm not going to help you until you stop your drug use.
Yeah.
We have to go much earlier than that. We have to start working with individuals while they're actively using with no expectations. Do I want everyone that's using to get help? And yes, without a doubt. But that's not how you approach somebody that's in the grips of active use.
Right.
So whether somebody wants to stop or not, we can still help them. We can provide them with naloxone, Narcan, so they don't die of an overdose. Mm-hmm. We can provide them with tools to prevent the spread and getting HIV or hepatitis C.
Right.
We can hopefully provide some type of counseling. Many drug users, their use is driven by mental health issues, by, like we said earlier, trauma, adverse childhood things that can successfully be worked on while they're still using. And if we can kind of get to those core issues, we are going to raise their chances of not using substances anymore. But if we go by the old philosophy of call me when you're ready to do something different, too many will die before that happens.
And they're not going to call.
Eventually people do, most.
Right.
But now with fentanyl completely poisoning our drug supply, the risk of death is so high that we can't just sit around waiting for the phone to ring. We have to actively go help people.
So, and you go out there. I mean, you actually go out to different areas and
My
help
team
these
does,
people.
yeah, not just me.
Yeah.
I have great employees. We have an ambulance that goes around. It's a vambulence revamped up. It goes around the city, helps people that are homeless. And, we also provide hepatitis C, HIV referrals for treatment, housing, lots of other things to raise. I mean, poverty in the city is horrible. Just to raise people's quality of life a little bit, because sometimes raising somebody's quality of life and giving them some hope that things can be better is another key ingredient in them achieving some type of recovery.
Wow. And so being, so many of us, we don't see it, right?
No.
It's just not in our neighborhood,
No.
right?
Well, no, it is.
Well, it is, right. But, those are the functioning people,
Yeah.
probably the 4 out of the 5. Although, I know.
3.5 run by stats.
Yeah, I got ya. Come on, Miss, get it together. But how did you come to find all these different areas that you guys drive to and help and?
Oh, that's just. I use drugs here. Before I got sober, we employ active drug users, and they know where people are. So we just
employ active drug users.
Yes.
Wow, that's awesome. I did not know that.
Just because you use drugs doesn't mean you lose your
Right.
human rights. Yeah.
But I think that makes a lot of sense. I think the model that you have put together is not one that most people would think of.
Yeah.
It's a perspective changing thought, right?
It is, but we're not trailblazers here. This, Sweden started most of this work in 1986.
Really?
And then Baltimore, we took a lot of cues from Baltimore from a group called Be More Power, which is a peer-run group. Lots of organizations will utilize people still actively using. We have one resident at our sober house now who was homeless, actively using. He helped us with some street outreach because he knew where to go. And then we spent working with him long enough and building that bond where he's like, all right, I'm ready to stop now. First time in a long time. And now he's one of the anchors at our sober houses. He's a leader. He's been in recovery now for a couple months. And it all started with just making him feel like he was worth something.
Right. That's amazing. I love it. Well, we'll take another quick break and we will be right back.
All right.
One more section. I just have some questions.
Okay.
All right. Ready?
I'm ready.
Okay.
And we are back with Chad Sabora. So, okay, Chad, let me ask you about this. So you have worked for reform, legalization of syringe access. Talk about that.
Okay,
Is that a
we're
funny
going
question?
we're going on year 6 of that legislation. So syringe access programs, formerly called needle exchange programs, have been around since the late 80s, legally. They are supported by our current Surgeon General, Vice President, last Surgeon General, last whole administration, CDC, World Health Organization, you name it, every single health body on the planet supports these programs. It reduces the spread of HIV, hepatitis C, it gets dirty needles off the streets. People that use syringe access programs are 5 times more likely to enter treatment. So it actually will reduce the amount of users in a community that has these programs.
Right.
0 people are initiated into IV drug use because of the existence of a needle exchange program. It's just fear.
But that myth is still out there.
Yes, that is
Still out there.
Yeah, so we have tried, I've tried, and my organization has tried for years to get this legislation passed in Jefferson City to no avail. We always get out of the House with only a handful of no votes, and then it always gets hung up in the Senate. We have a serious hepatitis C problem in St. Louis. Our infection rates are through the roof. Missouri has 13 counties on the CDC's hot radar list for possible HIV outbreaks.
And why won't they pass it? What is there? Why?
The stigma around it, they think we're enabling. You're just helping people get. Listen, a drug user is going to use no matter what, and we're going to use dirty needles.
Right.
We're going to share needles. People, and there will be no state or federal tax dollars that assist these programs. They're all done through private foundations such as AIDS United, Elton John Foundation, things like that. The amount of money taxpayers pay right now from the unintended negative consequences of not having needle exchange programs is massive. The state spends close to $60 million a year for treating hepatitis C cases. So needle exchange programs or syringe access programs could technically cut that in half. So For no cost to you as a taxpayer, we can save you $30 million a year. Many diseases, other diseases besides hepatitis C and HIV, can happen from reusing dirty needles or sharing needles. So there's millions of dollars of hospital bills that go unpaid from endocrinitis and other bacterial-related issues. So not passing this legislation costs the state of Missouri and its taxpayers upwards of $50 million a year. And there are zero consequences that would cause any type of tax burden on the citizens. No new drug users, no tax dollars are spent for the syringes, for employee salary, for things like that. So the fact that it's just common sense legislation, we had 3 very red states like Missouri pass theirs this year. Idaho, Alabama, and Florida all passed their syringe access bills, but we're still stuck here in Missouri.
Oh my gosh, it's just maddening.
Yeah.
You deal with a lot of difficult issues and people and subjects, and how do you, Chad, rejuvenate? How do you get up every morning other than coffee? I mean, what do you do to take care of yourself?
I got 2 amazing kids. I got Jason's 3 and Maddie's 1. So, I want a better world for them. I want to teach them better about, people that use drugs, and, teach them empathy, and that people deserve second chances and help. So just because of them.
And what do you guys go do? What's the fun stuff?
I mean, I work a lot.
I know you do, but you have to have some time where you're not working.
I'm getting there. I'm working on some balance right now in my life.
Got ya. Well, I got to meet your son, who was crazy adorable, by the way.
Yes.
And I mean, but what I thought was interesting is he's only 3.
Yes.
And I felt like he already had great awareness at being only 3 years of age. That comes from somewhere.
Oh no, he knows how to pick locks.
Oh.
He'll go to the bathroom door and he'll lock it and then close it, and he'll make this face, and then he'll run and get a butter knife, and he'll. It's really easy. It's not like
but
it's
still,
just,
but that age, you can figure
yeah.
that out. I mean, I was struck by that when I met him. Just watching him run around and the things he was saying and doing, I was like, this is a really aware kid at 3.
Yeah, he's awesome.
So congratulations on that one, Dad.
Thanks.
So tell us where everybody can find you.
We are open 7 days a week. MoNet Outreach Center. We're at 4022 South Broadway, St. Louis, Missouri 63118. We have an 800 number that's answered kind of 24 hours a day. So that's 844-REBEL-UP. So we provide hepatitis C, free referrals to hepatitis C treatment for the uninsured, naloxone access, treatment referrals, housing, peer support, tons of groups, free yoga, free acupuncture, free self-defense, family support groups, grief support groups. We just have an amazing group of women that help run this center. We call them our MoNet Moms. Moms that have children in recovery, have children actively using, have children that have passed, have all kind of come together to help us build this organization.
Wow.
And we're on website is monetwork.org. And we're in the process also, and we will open late July, early August. We are opening up a 55-acre residential treatment center in Dittmer, Missouri.
Oh, wow.
So that is Sauna Lake Recovery Center.
Very
so
cool.
saunalake.com is a website. It's still being built, but I think it's live right now. We don't have the best treatment in Missouri. We have some amazing facilities, but we always need more. So me and my 3 partners, we took a vision, we found the property, and we are working very diligently to make this a destination type of center to provide the highest level of care for people that need it.
Love it. Chad, thanks for all the work you're doing.
Thanks for having me, Mitch.
Thank you very much. Appreciate it.
Of course.
And for everyone out there, you've been listening to MichMash Podcast. Go to iTunes and subscribe. Have a wonderful day.